So, what is obesity? The definition of obesity is a body weight that exceeds the expected or ideal body weight by more than 10%. So, the alternative definition, what you can consider is when somebody weighs more than 25% of the weight, normal ideal body weight, okay, and there is excess of fat content in the patient when there is more than 25% of the body weight in males and 30% of in females is attributable to fat. Okay, normally 15 to 80% of the body weight is fat. Okay, this is the definition of obesity. Morbid obesity is defined as exceeding twice the ideal body weight, and these are certain formulas that you need to know. So what is ideal body weight? Adjusted body weight. Adjusted body weight is equal to ideal body weight plus 0.5 times the difference between the total and the ideal body weight. What is predicted body weight? This is mainly used in terms of ventilatory strategies when you are. So Dr. Jasmine had already mentioned in men 50 plus 0.9 into height in centimeters minus 152 in kgs. So in women 45.5 plus zero point 0.9 times height in centimeters minus 152. So this you'll get in the kgs. So this is mainly when you're looking into ventilatory strategies. So what is the classification of obesity? So this is mainly based on the body weight divided by height in meter squared. So underweight is less than, when the BMI is less than 18.5, it is underweight. Normal is 18.5 to 24.9. Overweight is when 25 to 29. Class 1 obesity is 30 to 34. Class 2 is 35 to 39. Class 3 is more than 40. So what is obesity paradox? So most large cohort studies in general population demonstrated there is an increased risk in both overweight and obese individuals. However, more recent data in hospitalized patients suggest that chronic illness has shown a J-shaped relation between BMI and mortality. So with overweight and moderate obesity, it has been associated with lower mortality. So this J-shaped relationship between BMI and mortality is known as obesity paradox. So we initially thought obesity increases the risk of mortality, but paradoxically, it is associated with increased survival. So that is known as obesity paradox. So what are the obesity associated complications? So because of increased adiposity, there is increased adipokine synthesis, more macrophages, inflammatory process that goes on, more cytokines, insulin resistance, and type 2 diabetes. And due to increased lipid production, the hydrolysis of triglycerides, increased release of free fatty acid, lipotoxicity, dyslipidemia, resulting in non-alcoholic fatty liver, steatohepatosis, and cirrhosis. In cardiac, there is a high risk of coronary artery disease. There is increased activity of the sympathetic nervous system that will result in high pulmonary arterial pressures. So that also proposes a risk of congestive cardiac failure, also stroke and chronic kidney disease. There is increase in activation of the renin-angiotensin system, which can lead to acute kidney injury and chronic kidney disease in the long term. Mechanical stress, because of the weight as such, there can be in more pressure on the joints, resulting in osteoarthritis, increase in the pharyngeal soft tissue, causing obstructive sleep apnea, increase intra-abdominal pressure, risk of GERD, and esophageal Barrett's esophagus. So the challenges we can face when managing with obese patients: airway related, respiratory and cardiovascular consideration, nutritional, thromboembolism prophylaxis, monitoring and investigation difficulties, difficult vascular access, nursing difficulties in terms of skin management, bed sores, and drug dosing in terms of lipophilic as well as hydrophilic drugs. So physiological difference, when we look into obese patients, they have high oxygen consumption, CO2 production, increased work of breathing because of the high intra-abdominal pressure. The compliance of the respiratory system is as such decreased. The FRC is also decreased. They are at risk of obstructive sleep apnea syndrome. And more important is the difficult airway component that we need to manage when the patient is really decompensating. Paradoxically, in a perioperative mortality in obese patients have not been very high. This is also one of the terms of obesity paradox. And prognosis in terms of ARDS compared to non-obese patients, again, it is better in obese patients. So difficult airway related, we all know the Mallampati score, mouth opening, cervical mobility, everything can be restricted. When you're having a patient who needs intubation and mechanical ventilation, pre-oxygenation, always attempt with an NIV with a little higher pressure support and PEEP, and a CPAP which is slightly higher. HFNC can also be used, okay, and a moderate PEEP. So ARDS better survival. And when ventilating these patients, reverse Trendelenburg can be tried. Prone position is not a contraindication, but if prone is not going to be possible in the ICU, consider VV ECMO early. Okay, what are the strategies that you have to do? So maintaining a ramping position. Ramping position is placing increasing the height of the shoulder and the head, so that your targus almost is equal to the ear, to the sternal notch is almost in the same horizontal line. So you elevate the head by placing a ramp under the head and shoulders. So this position is very important when you do the laryngoscopy and intubation. And pre-oxygenation, I already mentioned, you can try with a little higher PEEP with NIV or with HFNC. So ventilatory strategies in non-ARDS patients and ARDS patients. So your tidal volume for your ideal body weight. So just note the body weights for each and everything. For nutrition, it's going to be different. So everything for drug dosing, it's going to be different. So for ventilation, for your tidal volume, it's going to be ideal body weight, 6 ml per kg, ideal body weight. So your targets are almost same as you do for a normal patient. Your PEEP, you titrate according to optimal oxygenation, your driving pressures, plateau pressures, so less than 30, less than 50. But this is something that you need to understand. Your plateau pressures may not denote your lung compliance, because your chest wall compliance is going to be more contributory to your plateau pressures. Ideally, if possible, these are candidates who can benefit from titration of PEEP with a transpulmonary pressure monitoring. So that is something different that you need to remember. So prone position, go ahead if the PF ratios are low. So your ventilatory targets, you have to mention about the transpulmonary pressure that can be more beneficial in these patients. Cardiovascular system, again, the fat mass related pathology, increased blood volume, cardiac output, ventricular hypertrophy because of the increased sympathetic drive, and diastolic dysfunction, ventricular dilatation causing obesity, cardiomyopathy. Also, these patients are prone to have pulmonary OSA, hypertension related to secondary to OSA, hypoventilation syndrome, and they are also prone to thromboembolism. Okay, and the metabolic syndrome, which also proposes a cardiac risk in terms of coronary artery disease. So monitoring the hemodynamics is very crucial in these patients. Oscillometry method may be less accurate. Arterial line needs to be placed. In fact, sometimes you have to need a lengthy line in some scenarios, and also placement might be a little difficult, including the central venous catheters. Ideally, the peripheral venous access might be difficult in these patients. You'll have to go in for a central venous access. The transthoracic echo, there will be a poor window. So if there is a real need, transesophageal echo needs to be considered. Cardiac monitoring, esophageal Doppler, so those can be useful. So adjusted body weight. So your fluid resuscitation should be done based on your adjusted body weight. So we already saw what is adjusted body weight. It is nothing but ideal body weight plus 0.45 times total body weight minus your ideal body weight. So this you can do your fluid resuscitation based on that, had better outcome compared to actual body weight and ideal body weight. So vasopressors should be titrated to your clinical effect rather to clinical effect. In terms of renal, there is obesity related nephropathy. There is increased intraglomerular pressure. There is a high metabolic demand. Renal tubular sodium resorption is increased, and obesity related glomerulomegaly can be there. Focal or segmental sclerosis can also be present. Okay, other thing going into again obesity paradox. There's lower mortality in these patients with AKI and CKD. Okay, there is improved hemodynamic stability during RRT, and the fat tissue serving as a buffer for uremic toxins. Though encephalopathy, uremia related symptoms can be less in these patients. But the difficulty we might face in patients with AKI is that the criteria that we apply, that is oliguria criteria and all that, can be falsely positive in this patient because there is no ideal mention of which body weight we need to follow. Also, in addition, whether during CRRT, the dose of CRRT, whether it's the actual adjusted or ideal body weight, has no mention of it. So this is a cavity in the guidelines as well. So there's no recommendation for obesity. In terms of immunity and nutrition, so adipose tissue has some regulation in physiological and pathological process in immunity and inflammation. So several hormones like adipokines and classical inflammatory mediators result in a state of chronic inflammation. So their baseline CRP levels will itself be high. And there is a high rate of development of insulin resistant and more cardiovascular complications. The innate immunity as well as adaptive immunity is affected in obese patients. There is perturbations in the T cell immunity as well. But still, though we understand they are at risk of infection, there is obesity paradox, which has been described in these patients in relative to pneumonia and sepsis. So the outcome is good in these patients. Again, venous thromboembolism, a very high risk of DVT and PE. Abdominal compartment syndrome can occur. Skin related issues, it's a serious problem. Bed sores can frequently be there. Visceral obesity is also predisposing to high cardiovascular risk. It's a pro-inflammatory state, pro-thrombotic state, hyperfibrinogenemic. Okay, and regarding to prophylaxis, DVT prophylaxis, whether compression stockings, there is no recommendation for pneumatic compression devices, as well as the low molecular weight heparin, the dosing what we give may not be adequate for these patients. Okay. And ultrasound, in terms of investigations, echo, ultrasound, so all those may be impaired by the increase in soft tissue thickness. And coming to the drug dosing, hydrophilic or lipophilic. So depending on the nature of the drugs, the volume of distribution is going to vary. For lipophilic drugs, because of the high adipose tissue content, the volume of distribution is going to be very high. But which body weight you have to follow is that the adjusted body weight, it is more relevant than the ideal body weight. So you follow the adjusted body weight for both hydrophilic and lipophilic drugs. So this is, we have mentioned this already. So every organ, what are the changes Brain-related mood disorders can be there, social stigma, cardiovascular, chronic cardiovascular, ischemic heart disease, cardiomyopathy, increased cardiac output, okay, and risk of insufficient fluid resuscitation. Hemodynamic monitoring can be difficult. Liver-related non-alcoholic fatty liver, drug metabolism can be impaired. Nutrition-induced dyslipidemia, altered metabolism and pharmacokinetics of the drug dosing. There's a chronic inflammation, altered immunity, and increased risk of inflammation, but the outcome will be good. Obesity paradox again. Respiratory wise, decreased compliance, FRC, increased oxygen consumption, increased CO2 production, and increased work of breathing, kidney-related glomerulomegaly, focal glomerular sclerosis, and chronic increased risk of AKI and CKD. Okay, so hyperglycemia, dyslipidemia, so hidden sarcopenia, increased fat mass. So these are the various organ impact of obesity on various organ systems. When coming to the nutritional aspect, this is something very important that you need to understand, mainly because the different guidelines suggest different kilocalories, different protein, and whatever the body weight they consider is different. So international guidelines recommend using measuring resting energy expenditure with indirect calorimeter, but this is going to be something very, very difficult. Aspen guidelines recommend 65 to 70% of the resting energy expenditure. So if you are taking the actual body weight, the kilocalories that you need to be giving is going to be 11 to 14 kilocalorie per kg of the actual body weight per day. And if the BMI is between 30 to 50. If the BMI is more than 50, then you consider 22 to 25 kilocalorie per kg ideal body weight. So based on the BMI, you have to choose between actual body weight and ideal body weight. And if it's actual body weight, 11 to 14, ideal body weight, 22 to 25. And hypocaloric high protein diet with 2 to 2.5 grams per kg. This is as per the Aspen guidelines. It is based on urea concentration. So this is the Aspen guideline. Aspen guidelines suggest that 20 to 25 kilocalorie of adjusted body weight per day and no further adjustments below resting energy requirements. And the protein is 1.3 grams per kg of the adjusted. So Aspen suggests for both calorie and for protein, the adjusted body weight. So this is obesity related. Next topic, we'll be looking into the acid base disturbances, the different methods of measurement. So we know there are three methods, okay? I have just made a table mentioning the core concepts and the principles of and the differences between the three methods. So the first method, the traditional method, what we normally use is the physiological method or the Boston approach. That is the Henderson-Hasselbalch approach. So this was first introduced in US in 1916, okay? And the core concept is that it takes into account the respiratory and the metabolic components using the bicarbonate buffer system. This is based on this formula, the Henderson-Hasselbalch equation, where pH is equal to pKa plus log of bicarbonate divided by PCO2. So the key variables here are pH, PCO2, and bicarbonate. The strengths of this is it's very simple to use, widely used in most of the ICUs, and everybody is trained to use. We always follow the 7 steps. And it oversimplifies. Limitations is that it oversimplifies. It ignores the unmeasured ions and other buffers like albumin, phosphate, hemoglobin, all those buffers it actually ignores. So, and the cause for the acid-base disturbance, you will not be able to mention with the Henderson-Hasselbalch approach. Next is the base excess approach, also known as the standard bicarbonate approach. This was a European approach from Copenhagen, primarily used in polio epidemics and all that. There was an issue because of the measurement of base excess component alone, ignoring the respiratory variation. So this quantifies the metabolic component independent of the respiratory influences by calculating the base excess. So what is base excess? Base excess is the amount of strong acid or base required to return the blood pH to 7.4 at a PCO2 of 40 millimeters of mercury at 37 degrees. So this considers the base excess. A base excess of -2 to +2 is normal, wherein a more negative value is acidic and more positive value is considered to be alkalotic. Okay, also pH and PCO2 are taken into consideration. So this considers the whole body. The standard base excess method is actually considers the whole body influence and the influence of hemoglobin as such. But whether it's validated in all metabolic disturbances, no, it is a single value for metabolic disturbance, and primarily it is used in trauma. A negative base deficit has a prognostic significance in shock, severity, and need for resuscitation. In trauma patients, high base deficit denotes increase in bleeding or increase in need for volume replacement and blood product replacement. So in trauma, you have the classification of shock wherein base deficit is one of the components. So remember that. So trauma, sepsis, yes, it has a value. An abnormal, it assumes usually the standard base excess, what they are calculating is for a hemoglobin of 5, and then it is normalized, and then it is actually adjusted. It assumes normal hemoglobin and one compartment model. Okay, this is the disadvantage of it. The Stewart or the physiochemical method, this was proposed by Peter Stewart in 1981 in Canada, actually. So this is based on the principle of laws of electroneutrality, laws of conservation of mass and mass action. So when you have positive and negative ions, both should be equal in a system. So that is the basic concept of this physiochemical approach. So they consider two variables, the independent variables and the dependent variables. So these both are going to be the variables which are going to affect the pH. The three independent variables are PCO2, strong ion difference, and A dot, where the dependent variables are pH and bicarbonate. Okay. So the dependent variables vary based on the independent variables. So what is the strong ion difference? What are the strong anions and cations? Sodium, potassium, calcium, and magnesium minus chloride and lactate. So this is the strong ion difference. Whereas it considers the pH, PCO2, strong ion A dot, and strong ion gap. So what is the strong ion gap? We'll see that later. Strengths is that it takes into account the unmeasured anions and all, like albumin, phosphate, lactate effects, fluid effects. So everything it takes into account. So it is very complex. But still you will be able to identify what is the pathology or what is the reason for the acid base abnormality. So it is very important in kind of explaining the reason or etiology of the acid base problem. But it is very complex. The equation is going to be very difficult. You'll have to have a lot of variables that are available. You'll have to have the phosphate level level, albumin level, lactate level, sulfate, and you'll have to look into various amount of contributory factors. And whether the measurement, every lab, the measurement of some of the electrolytes can vary. So that can influence the strong ion difference as well. Okay, so validity is something, and the strong ion difference is something that depicts the plasma only, not the entire component, the entire body component. So when we are looking into the traditional approach, that is the Boston approach or the Henderson-Hasselbalch approach, here the pH is defined by the balance between the respiratory and the metabolic components. So bicarbonate and PCO2 are the buffer systems, important buffer systems. So as this equation goes, you calculate the pKa as well as you know the pH by bicarbonate and carbon dioxide. How will you interpret it? First, there are several steps of interpretation, wherein first step being know whether it's acidemia or alkalemia, looking at the pH, look at the PCO2, you know whether it's respiratory alkalosis or respiratory acidosis. Then you look at the pH and the PCO2, whether it moves in the opposite direction or same direction. So if it moves in opposite, it's respiratory acidosis. It moves in the same direction. Both are low, metabolic acidosis, and looking for the compensation. For example, the primary disorder, if it's kidney, whether the PCO2 is going to be compensating for the bicarbonate or not, or if the primary pathology is in the lungs, whether the kidneys are going to be compensating. So use the compensatory formulas and the rules to know whether there is associated mixed disorder. So for metabolic acidosis, you have the formula 1.5 times bicarbonate plus 8 plus or minus 2, and for alkalosis 0.7 into bicarbonate. So similarly for respiratory alkalosis and acidosis, for every change in the pH, for every change, 10 millimeters change in the carbon dioxide level, your bicarbonate will vary. For respiratory acidosis, acute setting, it is going to be 1, and for chronic, it's going to be 3. For alkalosis, acute setting 2, and for chronic alkalosis, it's going to be 3. So based on that, you can add to your bicarbonate and see whether it's and compare it with your patient's bicarbonate, and you will be able to know whether there is a mixed acid-base disorder. The next step would be anion gap, calculating the anion gap, whether the anion gap is normal, and also make sure the corrected anion gap, the factor is 2.5 for your deficit in the albumin. So 2.5 times your albumin 4 minus your serum albumin and add it to the albumin gap. So that will give you a corrected albumin anion gap. Next step will be looking at the delta ratio, anion gap, delta anion gap divided by delta bicarbonate gap. So if it's less than 0.4, it's pure anion gap metabolic acidosis. If it is between 0.4 to 0.8, it's mixed NAGMA and HAGMA. If it's 0.8 to 2, it's pure high anion gap. And if it's more than 5, it's HAGMA. Either a metabolic alkalosis can be associated also. Okay, that is our traditional approach or the Boston approach. Next is the base excess approach. So here it quantifies the metabolic component mainly. So the base excess is actually the amount of strong acid or base that needs to be added to a liter of blood to return the pH to 7.5 at a PCO2 of 40 and temperature of 37 degrees. And this mentioned in millimoles per liter. Okay, the amount of strong acid mentioned in millimoles per liter. The interpretation: less than, more negative metabolic acidosis, more positive metabolic alkalosis. So usually the modern acid-base analyzers calculate the base excess based on actually several algorithms or normograms that have been used, mainly the Vance-like, something known as the Vance-like equation. And this is done at a standard. When we get the standard base excess, it is for hemoglobin of 5. The actual is actually calculated for the patients or calculated for the patient's hemoglobin. So the simplified formula, okay, this is the base excess formula wherein it notes the bicarbonate, hemoglobin, and pH. Okay, it takes into account the three variables. And the base excess is calculated under the assumption that respiratory PCO2 are standardized. Okay, PCO2 are standardized, only the metabolic component remains. So this is similar to the steps we had looked into the Henderson-Hasselbalch approach. These are the various steps that we can use to make sure whether it's a acidosis or whether the compensation is there, whether there is an associated, that is a mixed acid-base disorder that is also going on, anion gap corrected with albumin, and then interpret based on the findings. So we'll look into it one by one. Acidemia when the pH is less than 7.38. So you look at the base excess. If the base excess is negative, less than more negative, then you go into the compensatory formula for the secondary respiratory compensation, your delta PCO2 and your base excess. There are formulas for this. So, and you look into your expected PCO2 and you calculate it. If it is lower, then additional respiratory alkalosis is there. If the PCO2 higher than the expected PCO2, additional respiratory acidosis is there. Then calculate the anion gap, correct it for albumin. Then normal anion gap, evaluate for the etiology. High anion gap, again consider your differential diagnosis, and in case of mixed acid-base disturbances, you look into the etiology. Last step would be to calculate the osmolar gap also. In case of respiratory acidosis, secondary metabolic compensation, there are formulas for this actually. So the base excess, you need to know. Base excess, the formula is 0.4 times the delta PCO2 in terms of chronic respiratory acidosis. And last step would be anion gap, albumin correction. So these are the various compensatory formulas that are available. It is difficult to remember, but if you want to, you can, but you need to understand this is how the steps are being done. For alkalemia, similar, the metabolic alkalosis, base excess is more than 2. pH is increased, PCO2 is increased, base excess is increased, and the secondary respiratory response, your PCO2, if you want to calculate, it is 0.6 times the standard base excess. So if the PCO2 is lower than the expected, it is additional respiratory alkalosis. If PaCO2 is higher than expected, additional respiratory acidosis. So evaluate for metabolic alkalosis. Okay, often what are the causes for metabolic alkalosis? You can identify. For respiratory alkalosis, then you go into the compensatory formula, secondary metabolic response. So standard base excess is equal to 0.4 times your delta PCO2 for chronic respiratory alkalosis. Then again 0.4 times. If it is less, then you need to actually interpret based on your values. Last step would be anion gap calculation. So that is about the Henderson-Hasselbalch and base excess approach. Next is the Stewart approach, that is the physiochemical approach. So it is based on the fundamental principles, three laws of chemistry, that is law of conservation of mass, law of electronegative neutrality, and law of mass action. So based on these, that is neutrality. So total positive is equivalent to the total negative charges. So this is very important. So there are three independent variables that are considered, and all the others are considered to be dependent variables. The independent variables are PCO2, strong ion difference, and ATOT. ATOT is weak acid. So PCO2, it is controlled by the lungs. Strong ions, what are the strong anions and strong cations? Strong anions are sodium, potassium, calcium, and magnesium, minus your chloride and lactate. So these are strong ions. The normal strong ion difference is almost 35 to 40. So 40 is something that you consider. If the strong ion difference decreases, that means it is acidosis. Then your anions are high. So that is acidosis. If your strong ion difference is high, that means your cations are high. That is alkalosis. Okay, you interpret based on your strong ion difference. The total concentration of the weak acids. So here it is not taking into account the weak acids. So the weak acids are albumin and phosphate, which are very important. So the weak acids increase in albumin or phosphate can cause acidosis, and your albumin and phosphate decrease will result in alkalosis. So the pH is determined primarily by the independent variables. The pH is determined by these three factors, and the secondary effect is by the dependent variables. Okay, so the dependent variables are bicarbonate and all. So how will you calculate the strong ion gap? So what is the strong ion gap? So first you calculate the strong ion difference. So this is how you calculate the strong ion difference. And when you measure it, there is something on, if you calculate it with this and you measure and you actually get the effective strong ion difference, measure it, and the calculated one, there is a difference between the measured and the apparent effective strong ion difference. That is the strong ion gap. So that denotes the hidden metabolic acidosis that is contributed by the unmeasured anions. So what are the unmeasured anions? It can be sulfates, there can be aluminum or some other ketones. So this can contribute to the strong ion gap. So clinical application. So you check for the strong ion difference. You will get to know what other contributory factors can be there. Check for the HATOT. So albumin and phosphate, the compensatory, and you calculate the strong ion gap. It can reveal the unmeasured anions. Okay, the main difference between the Henderson-Hasselbalch and the Stewart approach. Here they are looking into only two components. In the Stewart approach, here the metabolic component, the difference between the strong anions and strong cations is going to be your strong ion difference. Your ATOT is nothing but it is similar to the weak acids that is contributed by your phosphates and albumin. Okay, it's slightly it is almost similar to your albumin, but beyond this, your effective strong ion and your actual strong ion difference, if you are going to find a difference, there will be some strong ion gap that is mentioned. So the strong ion gap is is contributed by the unmeasured anions. So this you can see, if the strong ion difference is more negative, it is more acidosis. If it is more positive, it is due to alkalosis. So whenever there is a variation in water content in the body, whether it's excess or low, whenever there is a change in the sodium levels, so that can change the strong ion difference. So this explains the concept of normal saline induced acidosis. So when you actually give normal saline to the patient, you increase the sodium content, okay, and you increase the volume as such. So that will actually affect the strong ion. The strong ion of the saline is going to be low. Strong ion difference is going to be low. Whereas the strong ion difference of the other balanced salt solutions is going to be almost similar to our plasma. So how do you calculate which variable is attributing to the strong ion difference? So this is something that has been mentioned for the Stewart approach. So the variables which is more contributory, if you look into the difference between The sodium and chloride, it is considered 35. So if there is a excess deficit, that means the sodium chloride base excess effect. So how much effect each variable is contributing. So if the difference is more, that much effect is contributed by sodium chloride base excess effect. If lactate, 1 minus measured lactate, that is lactate base excess effect. For albumin, 42 minus the measured albumin into 0.25 times. So that is albumin base excess effect. And overall base excess effect is addition of all three variables. And this is your that is your unmeasured and acids, actually your unmeasured acids. This is the calculated one. The actual measured one, if you look into that, this will be your unmeasured anions. This will be the contribution. So this is the simplified way to base excess approach. So we come to the end of today's session. I hope things are clear to everybody. If it is complicated, just remember this table. So if you are asked such a question, you can mention the core concepts, actually, what every method is taking into account, and then the equations and what is the main principles, core principles, and major strengths and limitations. And there is a good paper in NEGM. I'll share it based on the base excess method. You can go through it in detail. It's very complex, but you can go through it. So these are the various methods of ABG measurements. Any doubts or anything? I know it's a very busy day and we have extended beyond by half an hour. Guessed almost 12 of you are staying back. Any additional material that you need in these or anything that is not clear, we can share additional material on this.